Mark. It's an honor to be invited to share a little bit of information and what I'm doing with such a prestigious group of international colleagues. I have got a lot of slides, but we're going to go really, really fast, just in ways of review. I have to make disclosures that the University of Texas at Arlington is a Laerdal Center of Excellence. Although if I mention any products, this talk is not being sponsored, and I'm not promoting any particular product. I will mention a couple of games that I've been funded to develop, so I want to recognize the funders as Health Resource Services Administration and the University of Texas System grants. Just a couple of objectives, and I'm not going to read to you. As Mark said, the slides are posted, so you can go back and review some of the information that we fast forward over. We're going to be talking about simulators rather than simulations necessarily. And what do we use them for? Here at UT Arlington College of Nursing, I use them to teach with and to evaluate students with. And these are the different areas of teaching and training. I use different types of simulators with the students with. And just as every educator, I begin with a theoretical background, and you all are very familiar with these types of theories. All of them center around adult learning, experiential learning, which all of it feeds into the idea of using different types of simulators to provide these experiences for our students. Deliberative practice with Erickson has really come to the forefront in the last few years, and all of us that are very mature in our practices realize how long it took us to get where we are, and the ability to do some of the things that we do took years of being exposed to those opportunities to do high morbidity, mortality, and low frequency. And so we're going to look at ways to eliminate those problems and talk about ways that we can link these different these models of education to interdisciplinary students rather than educating our students in silos, which is something I've been attempting to do here in the North Texas area. Now, when I started teaching, I'd been a practicing nurse practitioner for over 25 years, and I was very familiar with linking theory to practice. I grew up professionally in an academic medical center and became very familiar with David Sackett, and I'm sure you all recognize who he is, almost the father of evidence-based practice. And his Venn diagram is renowned in how he approached using evidence in order to take care of patients. Evidence, of course, is very important, but it's always coupled with your clinical experience as a physician or a provider, and also taking into consideration the values of the families and the patient. It's not just systematic reviews. I know that's heresy, I realize that, but I said it anyway. So I took Dr. Sackett's model and I applied it to education. Oh, look, I misspelled evidence. Taking evidence from the educational literature, looking at trying to develop my own expertise as an educator and a faculty, and then considering the different learning styles of my students. So looking at the evidence, it's been fairly clear over the last few years, and I just listed a few of the systematic reviews that I'm sure everyone is familiar with, and bulleted the items that repetitively come up as being important components of simulation. And nearly every one of these bulleted points are mentioned in the most current systematic reviews. So we do have evidence that using simulation is an effective tool as long as these components are present. What about the expertise of the faculty or the educator? Well, I'm not sure that we're quite as far as where we need to be in terms of validating the competency of the educator. There's been some work with the Express group helping to um, um, refine the process of debriefing by using some scripted debriefing. I think there are some organizations that are beginning to offer certification for people that educators or facilitators of simulation, but I still think that we are probably not quite where we are in terms of validating the educator. And what about the learning styles of the students? Well, I think there are all sorts of types of, and I'm going to flip back here. Um, there are all sorts of students that we all encounter, and we're familiar with the 7 most common learning styles, whether it's visual, auditory, verbal, physical, logical, social, or solitary. And as we train our students and educate our students, we need to take into consideration of how each of our students learn and how we can optimize the technology that we have available and the resources that we have available so our students learn what they need to learn. Looking at the different types of simulators, many of you are familiar with the most common types, and I'm not going to read each one of these to you, but you'll notice my last bulleted point is an integrated model of education where you use each one of these types of simulation based on some different factors. So how do you decide? Well, it should be driven by the educational goal or objective. If you're going to teach a psychomotor skill, you might want to start with a task trainer instead of a $40,000 simulator. You also want to look at the level of the students you're teaching. I have undergraduate bachelor's of nursing students here as well as master's and doctoral students. So when I utilize a simulator or incorporate a simulation into their training, I have to understand where they're at. I come with certain assumptions about the students. And if those assumptions aren't true, then the simulation or the simulator is not going to be effective. And then again, using as many different types of media and simulators as possible so that I hit the correct learning style of my student. So I'm just going to briefly go over, and I'm trying to keep an eye on the clock. I want to respect your time, but looking at the strengths and the limitations of each of the different types of simulators that are available. Computer-based simulators are really some of the newer types of simulators that we've been encountering. You may in the literature find them as patient-based, computer-based, virtual-based, a lot of terms. It hasn't been really standardized yet, and so when you're looking at the literature trying to find the evidence for a particular type of learning opportunity, it's going to be a little bit confusing. We're not quite there yet to what we're going to call it. But what we do know is that computer-based simulations are easy for the student to access. They can be very flexible. Unlimited access is a huge benefit of computer-based. The student is not limited to brick and mortar. They don't have to wait for the sim lab to open. They don't have to wait for an instructor to be there. Different kinds of computer-based simulations can be accommodating to the pace of the learner, so you can use them in various levels of students. Some of the games that have had the privilege to work with, the facilitator can, using sliders to increase the level of acuity, change the gender, age, and ethnicity of the patient, as well as making it more complex. We know that computer-based games, and I'm trying to stay away from games because I think that relays a message that we're not really wanting to relay. So computer-based simulations can, you can create some very immersive and engaging environment using high-fidelity 3D gaming techniques and technologies. The again, one of the nicest things about them is you can find them on many different platforms. Some of them are you can be purchased off of the shelf. Most of the prepackaged commercially available games or computer-based simulations are for first responders. There's been a flurry of activity in the market for first responders because that's sort of a standardized approach to education so that you can do some of those sorts of emergencies. You can get them for any of the handheld devices, Xbox, PlayStation, and so on. Some of the limitations: there's no physical interactivity with a real person. When you're programming a game, or when the programmers, depending on the gaming engine that is used and the capabilities of that particular gaming engine, the only two I'm really familiar with are Unity, which is an internet-based gaming engine, and it has some limitations as well as some positive aspects. And then Unreal 3 engine has a lot more flexibility and usability and fidelity, but it is a single player game and it can only be accessed on a single PC. They tend to be more computer DVD driven, or a game that you use in your Xbox. There's for the off the shelves that you buy, there's variability in the fidelity, and if you're going to do them using funding, the startup cost is very, very costly. But once they're developed and they're validated, then you can use them over and over and over again. However, you have to be careful about the information you put in them, because if it's dynamic information is going to change frequently, then a game is not, or a computer-based simulation is not necessarily what you would want to do, because you really can't go back in and reprogram them with new information. So they're really better for static information, i.e. first responders. There is literature that supports that they can be used for critical thinking, measuring it, as well as remediating the ability for learners, knowledge acquisition and application. The question always for me was, can they apply what they learn in a game in a physical environment? And some very, very preliminary work that I have done and others have done says yes. But again, I wouldn't extrapolate a lot of validity from that, because there needs to be a lot more research done and publication. You can teach time management. By cutting the game off. You can teach processes of step by step how you go through something. And then again, deliberative practice is one of the strong points of using computer-based. Now, virtual patients may be considered falling into the same category, but they are used a little bit differently. One of the most famous that you can find is Justina. She was created at the University of Southern California by a group of psychiatrists. She is an adolescent with PTSD, and she is used to teach psychiatric residents and fellows how to do an interview. When the participants go in, they don't know what Justina's problems are. They have to ask the right questions, eliciting certain responses to be able to make the diagnosis. There is, again, a limitation to Justina in that you cannot program all possible responses. She is not mathematically modeled. She is computer generated and using HTML. So when you use computer language to program responses based on interventions, you're always limited to either A, B, or C. It can't be a multitude of possibilities of responses. Many medical schools use models like Justina to teach interviewing. history taking to their medical students, and they're very effective in that manner. Once again, the same strengths, access, the students can access them anytime. As long as they are, again, receiving those 6 components that we have identified in systematic reviews as being effective, receiving feedback consistently throughout the process, they can be very effective. They can be economic. Once you developed a patient that you're just doing histories from, it can be used across the disciplines. Again, self-paced learning, good for varying levels, but especially lower levels. Limitations are the same as with any computer-based simulator. There's no real interactivity and variability in the fidelity. And again, the startup can be quite costly. And again, interview techniques, history taking, and they're very good for psychosocial. Probably used more frequently in medical schools, teaching history taking to medical students, and then psych mental health area of medicine. Task trainers are obviously low cost. They're good for beginning to teach procedures, very low fidelity, but they are good for psychomotor skills to get the sense of what it feels like with your hands and your arms and the positioning as you do different things. And I just have a couple of models there for you to see. Haptic devices are real popular right now. They're especially become prevalent in the surgical area. Surgery lends itself easily to haptic devices and other areas that have invasive procedures. They're not new. Haptic interfaces. Haptic devices are simply physical devices that are connected to computer software that interface with the software while the participant is going through whatever process they're supposed to be going through. They've been around since the 1950s. The first handling of radioactive substances were developed. They were very cumbersome haptic devices. If you're as old as me, you can remember seeing them on TV. They're, again, popular for minimally invasive procedures. There's very good evidence that residents trained, surgical residents trained using haptic devices go through the process of their surgeries faster with fewer complications. And these are some of the more frequently talked about haptic devices. These are called box trainers. The last two are box trainers. They're standalone, and you can see that it provides the participant an opportunity to actually feel the devices that they're going to work with in the real environment, and then be able to see on a computer generated screen what they're doing and how to correct maybe some of the things that they're doing. The really nice thing about having a computer interface that shows you what you're doing is that it teaches self-correction. We're really good about teaching a process of how to do something correctly. We're not quite so good at teaching how to people to recognize when they've made a mistake and how to self-correct before they even make the mistake. And haptic devices are good for that. Again, some of the strengths and uses that we've already talked about. Limitations are notable. They are very expensive to develop. They're hard to get funded for grants unless you have a very robust sustainability plan that you are going to present with your funding opportunity. And unless there's really a market available or a projected market, they're going to be very difficult to get funding for. So looking at something like neonatal intubation or something needs to be broader and maybe look and not just the population of nurse practitioners and neonatologists and pediatric residents, although they are really not going to fall into that category any longer. We may need to be broader looking at anesthesia and paramedics and first responders. Human patient simulators, you're all very familiar with those, and I'm not even going to read over all the strengths of them. You know what they are. Those of you who implement programs using high fidelity simulators or human patient. But once again, they're very costly. The students have limited access. They're dependent upon human availability. In other words, the instructor's got to be there. The sim lab has to be open. Typically, it's Monday through Friday, 8 to 5. You need a significant amount of technical support while you're running them. And there are still some areas of limited realistic human interaction and human realism. Very dependent upon using moulage, different types of makeup, to create some of the things that we need to create. They're very sophisticated, however, in the cardiorespiratory realm. Standardized patients actually have been around since the 60s. They once again were initiated use in medicine back in the 60s, actually hiring patients with particular signs and symptoms that the instructor wanted the students to encounter. So therefore, if that is the case, there is very high realism. You have the opportunity for interpersonal and emotional responses, communication skills, interrelational skills, very good for evaluation. We actually use our standardized patients. We've developed a form, and they actually are parents, if I hire a standardized parent, to actually evaluate the student, and they've gotten very good at doing that. Some of the limitations with using them as patients, if they're an actual patient, it's very hard to standardize a script. They don't tend to want to stay on script, so therefore it's really your playing field for your student is not level. When you hire people, a patient, you sometimes cannot really manifest the particular symptoms and make up the signs that you want the student to experience, especially if it's during a history and physical taking. They do cost. There's a lot of legal aspects of hiring standardized patients, background checks, and those sorts of things, and there needs to be a well-defined program of how you do that. And children, obviously. We have a few mother-child dyads that we have contracted with, but the liability of using children is very, very high for the institution. Virtual worlds. What is a virtual world? It is, think about Facebook, except it's a networked virtual reality place. Second Life is the most popular one that we're all familiar with. It is a three-dimensional network world that stands alone on an independent server. It is run by a for-profit company. This particular one is Linden Labs, and it really did start as a social network, except it was more physical. You went into the virtual environment, very much like modeling in a gaming environment, created your own avatar, and you could socialize going to different places. It's sort of caught on with many institutions buying areas within Second Life to create different types of simulation experiences. It does look and feel like a gaming environment. It can be multiplayer and be internet based, and these are some of the professions that are now using it. Some of the limitations are notable. You can get a free subscription, but as an individual, however, you can't really do anything other than visit the open areas within Second Life. If you want, quote, land, which is a space on their network, you can buy it, but most islands start at around $1,000 for nonprofits. UTA owns an island, and we pay a little over $1,000 a year for that. You have to be careful because this is not monitored nor regulated. So there are land barons that will sell you land and sell you gaming and modelers so that they can build on your property. You have to have the technology to be able to build on it. So it's not just the land; it's the ability to develop the assets that you want. The one of the major limitations is once you build on Second Life, it's stuck there. In other words, if you wanted to take that and pull it out and put it in a different platform, you can't. It then becomes the property of Second Life. Um, the integration of audio and video files is very limited and very obsolete and cumbersome. I've done some research with undergraduate students, and I found it to be very difficult and very limiting. And again, because it's an open environment, there is some antisocial behavior that you run into. So what do we want for the future? Everyone is here today because we are educating someone, and we know that what we teach and how we teach and the effectiveness of our education is going to ultimately impact whatever patient population you love and you take care of. So I think rather than throwing out any baby with the bathwater or jumping onto any one bandwagon with a shiny new toy, we need to really look at an integrated model of education. I tell my students right now, they're never going to get away from reading. You have to have the baseline of knowledge, the underpinnings, to be able to do any of the things that we want to teach them to do. And I think every one of these items or these areas of simulation are effective in the right place. I think where we are right now as a community is trying to figure out which simulator is the most effective for what kind of teaching and training, and then become efficient and effective educators, facilitators, knowing which one to use and when to use it and how to use it.